A very good afternoon to everyone. Before I begin, I would like to thank the IOS for inviting me for this session. As important it is to know how to implant the ICL, I think it's also important to explant the ICL, and we need to know what are the clinical case scenarios where we need to explant the ICL. So that's what my talk is going to be about. I'm going to just show a video where I had to explant the ICL in these two cases. So this is my first case. This is a 26-year-old female patient who has undergone ICL surgery elsewhere about 5 months ago. As we can see that the ICL is flipped upside down. The vault is very low and it is touching the lens. So she has a cataract. Her intraocular pressure when she presented to us was 36 millimeters of mercury. The operating surgeon here has attempted multiple YAG PIs, but still the intraocular pressure remained to be 36 millimeters of mercury. So what we planned to do here was to explant the ICL. We are injecting some viscoelastic to protect the cornea, and then going ahead with our main incision. I decided to enlarge just a little bit so that it's easier for me to explant this ICL and then remove it from the sulcus, use forceps, and then go ahead and explant it. So it was fairly easy in this case. Her intraocular pressure remained high even after explanting the ICL, and she anyways had cataract. So she subsequently underwent trabeculectomy and phacoemulsification with the PCIOL. Now, my second patient here is a patient who has undergone ICL surgery 10 years ago. Then after that, he suffered a shuttlecock trauma, and this is what happened. He has now corneal decompensation, a fixed dilated pupil, an ICL in place, and he has a cataract. So the first thing we did here was to do an anterior segment OCT to see the corneal clarity, the stroma. And then the axial length here actually was 31. Again, this is a manual entry. The IOL power plan was +2 diopters in this patient. He's a high myope. I had a little bit of difficulty in getting this lens out. It seemed to be a little adherent, much more difficult than the first case where the ICL had been implanted recently. Finally, with a combination of different forceps, I could manage to get it out the eye. And we are going ahead with the cataract surgery now. So as we know that the capsule can be a little fibrotic and might be a little tricky to deal with these cataracts post ICL. The lens here is very, very soft, so I just hydroprolapsed it, and then I'm going ahead with basically just using vacuum of 400 millimeters of mercury, hardly any energy used here, and then we decided to implant the IOL, and now we decided to go ahead with pupilloplasty because he has this fixed dilated pupil, so I'm just trying to tug on the iris a little bit so that it's easy for us to pass these sutures to do a pupilloplasty for him. Still, we could not get a very nice round pupil. And he is now subsequently was planned for a DSEC surgery at a later date. I decided to do it as a two-step procedure rather than combining DSEC at this stage. And this is the end of it. We placed a bandage contact lens in the eye. Thank you.
So, if the lens was flipped, why do you think there was chronic raised intraocular pressure even after you explanted the lens?
Yeah, so I think she said that the surgery had been done 5 months ago, but probably the iris got stretched because it was in that position, although it should probably take longer, but even in 5 months, because the lens, the ICL was upside down and it had been pushing the iris up. So it was basically like developing a secondary angle closure glaucoma. And so she, the angles had become very, very narrow. So that is the reason why I think the IOP we were also a little skeptical that, okay, the cataract is there, but IOP should have been controlled if it was just 5 months post ICL. But that just goes ahead to tell us that how important it is that we ensure that we have put the ICL in the correct position. And as a surgeon, if you have flipped it and you have put it the wrong way, you need to really explant it and put it in the right direction. So that is the reason why, even in spite of the operating surgeon had done multiple YAG PIs but not explanted the ICL, but still the pressure remained to be high even after the explant.
Sir, I have a question. Yeah, go ahead. Yeah, please.
I have a few queries. Number one is that, of course, you have not done the multiple PIs. I mean, like, PI, why is it done? That's the first query of mine, but you can't answer it because somebody else has done it. Second is that a gonioscopy would, I think, have given you a lot of answers. And a preoperative, and I know that in our center, guys just will not do an ICL without getting a gonioscopy done. So again, that's not your this thing.
Yes.
But when the person came back, maybe that would have helped you uncover a lot of things. Second is, why did you do a trabeculectomy? Were medicines not effective enough?
Yes, so we waited for, so first thing is YAC PI, if it was my patient, first of all, I would recognize it on table if I flipped the ICL and remove it. And secondly, if this, God forbid happens to me, I would not do YAC PIs for her. I don't think that's the way to go. You need to explant this ICL as early as possible. That is the way to go. That's what the operating surgeon had done. She had just come to me for a second opinion. And the second question was that the intraocular pressure was not controlled. So this patient had to be counseled a lot. So that's the reason why we waited for a month. And she had only been planned for cataract surgery later on. That too we had to plan in a second sitting because she was quite taken aback with the fact that she has developed cataract post-ICL. We waited for a month, even on multiple maximum medication, her intraocular pressure consistently was above 30 millimeters of mercury. That's the reason why we took her for a combined surgery.
I have reservations on this. I'm sorry about that, but I have reservations because I know what a trap does and how difficult a trap is. And to manage a trap, a young patient, I would have definitely wanted to. You see, you can't give 1 month medicines and expect that the pressures will be controlled. No, they won't. There's been so much of inflammation in the eye. First, you have to control that. But look, you have managed the case fabulously. If the case has been managed, patient is comfortable, it's all fine. But yes, I wouldn't have done it that way. That's everyone has his own point of view, so it's okay.
Ma'am, even if the pressure continued to be even apart, in spite of Diamox maximum medication, if it continues to be above 30, you would just do a cataract surgery?
I would have waited. See, the optic nerve doesn't go zoomp. It takes time. It takes time. And it's a young patient. And so if you give it, and that too, you can't take the eye and just load up with medicines. You can't. Just give that eye time to settle down. Believe you me, so many eyes just settle down. Just give it time. And especially just imagine, first of all, the PIs. That itself would have taken out so much of pigmentation. The trabecular meshwork must have got absolutely blocked. Again, after that, you've done fantastic surgery, but surgery itself has released so many prostaglandins. So again, on the trabecular meshwork, which has been bashed up, now you have done another. Obviously, that eye is going to say, yeah, hang on, wait, I need to settle. So it's just that. So you've done a great job, but I would have done it a little in a different way. I would have waited.
Thank you for the input.
Maybe it's my grey hair, that's it.
That's where experience comes in, I think, and
Yeah.
as young surgeons, we tend to kind of jump into.
That depends on how the patient is improving. You can't say that I'm going to wait for this time and I'm going to wait for that time. You monitor the patient very closely. Check the pressures regularly. Check whether the inflammation is going down. Would have definitely treated with a lot of anti-inflammatory agents. Keep on checking back. If the patient's eye is comfortable, only then I would have taken up the patient for surgery. And as I said, as Dr. Lal has said, I mean, like, it's okay. If you can't manage, then you go for a trap. But I would have waited.
And here I would like to quickly add that, doing like in our center at least, we have a protocol that first post-op day all patients get an OCT and we document their vault anyway. So if you have a flipped ICL for one reason, like even if it's a beginner surgeon who's doing it, you will still pick them up on next day, and even on subsequent visits we do document the vault.
Yes,
for
absolutely,
visit.
sir.
That picks up if you're going
Absolutely.
to miss, just in case you've missed it on table for some reason.
Yes, absolutely.
But
sir.
thank you so much.